So our topic is virtual physicians and virtuous avatars, which I won't attempt to define explicitly in philosophical terms, only to explore some of the questions that emerge from the use of technology in medicine. No financial conflicts of interest. I acknowledge that I have received some personal compensation in the way of moral guidance, spiritual support, and salvation from the great physician. Being human is our topic this weekend. Our humanness is often mediated through or represented by technology. And in our interactions with technology, we may gain a sense of what it means not to be human, which may then illuminate what it means for us to be human. And I'll talk about that within the context of medicine. In medicine, do technologies that extend our reach and our influence and our power to combat disease make medical care and our perceptions of other people more human or less human? And if so, why? So I'll turn to stroke. Stroke is an important problem in my field of neurology, the fourth leading cause of death in the United States, a leading cause of long-term severe disability, a cost of tens of billions of dollars a year. We have four main blood vessels supplying the brain. When plaque forms within one of the main blood vessels, you can have dislodgement of that plaque leading to the brain. This is a CAT scan here of an acute stroke showing death of brain tissue due to lack of circulation. So we want to prevent stroke and treat it acutely. One of the best treatments we have acutely is TPA, tissue plasminogen activator. It's basically a clot dissolver, and it can be very effective in lessening the impact of a stroke. It has to be given within the first 3 hours to be effective. Not everyone lives within 3 hours distance of a neurologist qualified to give this drug. And you don't want to give it indiscriminately because it does carry some risk, about a 6% risk of cerebral hemorrhage. This is what a cerebral hemorrhage looks like on a CAT scan. So clinical judgment is necessary in order to give this drug safely. So how do we reach the patients that live more than 3 hours from us? Technology can help. At our institution, we have a stroke telemedicine unit where we have relationships with emergency rooms far from us where there is not a neurologist available. When the patient presents with an acute stroke, our team can be activated. A neurologist then connects through a audio-visual connection with that emergency room and speaks to and examines the patient at a distance, a patient that we've never met, someone who's a complete stranger. This is another form of human interaction mediated through technology, and telemedicine is being used in other areas as well. I use this as an example. This is my colleague, Dr. Kevin Barrett, doing a stroke telemedicine consultation. I've carefully chosen a picture with no patient information in it, but this is what it looks like. He's got his headgear on and he's looking at the monitor. There's a camera that's photographing him so the patient can see him and they can interact in real time. But what if you don't have the best possible face to put on camera? Here's an example of another neurologist in our department. What if it's not the best face for a telemedicine consult? Patients or consumers might give higher ratings of satisfaction to a personality that's different. So could we use technology to alter that image? We could maybe digitally enhance the face, get rid of the red eye, brighten the teeth, do a voice makeover perhaps, or perhaps some patients would like a more feminine appearance, perhaps a female avatar we could substitute in, change the voice, change the face, and then my interaction with the patient would be even one further level removed. That might be better. And is the care provided through a telemedicine encounter as human as that delivered in person? Which is a question that I've tried to get at in a research study. And then could a virtual physician, someone who is more technology than human, be virtuous? Is virtue an attribute that we would want to attribute to technology, or is that reserved for human beings? And could digital enhancements engineer a more virtuous avatar if we had the ability to exaggerate not only the visible and audible qualities of the entity interacting with the patient, but also editing out some of the human foibles that might be present. The moral equivalent of red eye deletion. We could tweak the image, maybe tweak the moral and ethical attributes of the entity engaging with the patient, all through technology. We already have an example in voice changing technology. You can buy one of these to connect with your telephone, and then the person at the other end hears a very different voice than your own, and it does this in real time. It seems to me just a short jump to move to instantaneous video editing, so that you can take my image and transform it to have Paige Cunningham interact with the patient, and I'd get higher patient satisfaction scores, I think, if we enhance it in that way. But what is it about the human interaction that's important as a physician? This author, writing an article on, or actually an interview on virtue ethics, Dr. Chris Janssen, says that virtue ethics, as contrasted with professional medical ethics that focuses on formal rules, regulations, highly abstract deontologic principles, is attentive to what used to be called bedside manners. What do we mean by that? Dress code, demeanor, manner of speaking, politeness, etiquette, cultural sensitivity. These are aspects of the professional engagement with patients that we associate with the human element in medicine. And it seems to me that all of these things could be mimicked by video or editing artificial intelligence. If we're not close to it, in theory, all of these things could be manipulated or generated by electronics. So it doesn't matter even whether a human physician is present in this encounter. Does it matter whether Dr. Barrett here is human or just a machine capable of doing what the doctor does? He's actually not physically present in this encounter. Does that matter in terms of having a human connection with your physician? He's actually performing standardized tasks, things that a computer perhaps could be taught to do, if not now, in the future. So listing out what elements of this interaction we might call human or essential for a human connection, there's his knowledge, the ability to touch the patient, to reason, to apply clinical judgment, his dedication, his empathy, compassion, self-sacrifice, his physical presence, authenticity of identity, the fact that he has human hands, a human face, his own personal vulnerability that he shares with the patient, and a sense of finitude, as we thought about last night. All of these are part of the human element. We could divide them up into human actions and beliefs, motivations, and there are certain aspects that are just part of being human that I find difficult to classify. It seems to me that technology could modify or enhance or in some instances substitute for many of these attributes. And then what does that leave us with what it means to be human if we can forecast an artificial intelligence that might be able to do many of these things? What difference does it make to be physically present at the point of action, to be with the other person, immediately available, sensitive, vulnerable, in person? What difference does it make? We have the extraordinary benefit of providing a consultation and making a medical decision at a distance and potentially saving someone from severe disability or death from a stroke, but we can't actually be there. And technology allows us to mediate that difference, that distance. Does human touch matter? This is an example of robotic surgery contrasted with the human hand holding a scalpel. Does it matter whether that touch is human? There's some types of robotic surgery that can have better outcomes now than human surgery. The image of both of those. The image comes to my mind of a sewing machine where the hem gets stuck and you can't turn it off. But there are extraordinary gains being made through robotic surgery. And does it matter if there's a machine interface, another example of a robotic surgery and the human hand holding scissors that have fingers that feel, are sensitive, that are the same type of being as the patient being operated on? Does that make a difference? So I want to ask you, whose name here do you recognize? Who recognizes Brian Cooper? I didn't either. Neil Armstrong. All hands go up. Stanley Sarnoff. Jacques Marescot. You're all, yeah. Sarnoff is probably the most well-known, and of course we know these are their faces. We know Neil Armstrong because he walked on the moon, and I was there. At least I feel like I was there because I saw the rocket blast off, and I watched with interest on television. I felt like I was there with him. I was 9 years old at the time. What's interesting about these other people, Brian Cooper was the first to pilot the rover on the surface of Mars, an historical event almost equivalent to Neil Armstrong walking on the moon, much farther away, the first human being to navigate on another planet. But we don't know his name because a couple of reasons. One is it takes a large team of people to mount a project of this scale, so he just played one role. And the other members of that team are equally to be praised for the success of that project. And we can't, our minds are too limited to remember all of their names. But also there's a distance element. He wasn't actually there. Stanley Sarnoff, the first to transmit an EKG by telephone, leading to a cardiac diagnosis. And our Marescot was the first to perform robotic surgery transatlantically from New York. He operated, took out the gallbladder of a patient in France from New York City through robotic surgery. The first time that was done. So these are historical moments, but we don't recognize the names of the other three people, partly because they weren't actually humanly there. They did what they did through technology intervening. So here's Neil Armstrong's footprint on the moon. He was there in person. What does that mean for being human? He spoke about what it was like to be there. We could all watch and listen. What it was like to step onto that crunchy, powdery surface of the moon, to hold lunar rocks in his hand, to look up at the blackness of space and see our home, Earth, at a distance. And we could feel like we were there because there was another human being like us who was physically there, who could communicate. So I felt like I was right there with him. I remember that moment in history. So presence is important. And distance changes the way we look at a situation ethically. This is a drone, a military drone, where someone in the United States with command authority can click a mouse, essentially, and cause a missile to fire, killing a group of people somewhere else in the world. You're not there physically, you don't see the impact, you don't hear the missile, you don't see the faces of the people who are killed. There's a level of separation there that may make it easy to be less morally responsible. I'm not saying that the drone program is morally responsible, but the technology sets it up in such a way that you can psychologically distance yourself from the consequences of your action. So remote presence can detach us potentially from our patients, who we only see in a limited context if we're not in the room with them. We need to be aware of that as physicians and think of ways to overcome it. But the opposite is also true. This is an example of a soldier halfway around the world who was able to watch the birth of his daughter by Skype through a remote connection. He couldn't be there in person, but to see his daughter, to hear her first cry, and to see her baby face, and to see his wife in the delivery room when he couldn't be there in person, also has an ethical component. It's going to solidify his sense of personal responsibility to his family in a way that couldn't have happened if he didn't have that computer connection. So technology can enhance our community interactions as well as distance us from other people, depending on how we use it, the dual aspect of technology. So in our study, we looked at one essential aspect of the human element in stroke medicine, that is empathy. I put together a protocol a few years ago. We've just completed the research and are working on the manuscript now, but I want to show you some preliminary results. I wanted to look at the patient's perception of the neurologist's empathy during that telemedicine encounter and compare that using the same scores of a patient's perception of empathy in an in-person emergency room consultation and see what the differences were so that we could ultimately learn how to use this technology better in a more human way. And I wanted to compare the same people at the same level of training in both settings. So we weren't able to recruit as many in the in-person as through telemedicine. Looking at all the empathy measures that exist out there, the best one was the one developed in Scotland, the CARE measure, the Consultation and Relational Empathy. It's a 5-point Likert scale, and these are the questions that are asked. But I also supplemented it with a second scale, which I'll show you in a minute, that was designed more explicitly for this type of encounter to ask the sort of questions we're interested in. These are our CARE results, and we have the in-person scores here. This is good, this is bad, and the telemedicine scores compared very favorably to the in-person consultations. So we're doing this right by and large. The couple of low scores, the outliers there, I don't know if they had a worse outcome. We're looking into that. But at least this tells me that it's possible to convey empathy in this new type of distant relationship. Hopefully this in a similar way that the soldier seeing the birth of his daughter was able to connect at an emotional level. So we're trying to learn how we can do this well so that it doesn't distance us from our patients. The other measure, the telemedicine patient satisfaction measure, is a scale I came up with just for the purpose of this study, and it also showed very favorable results for the telemedicine cohort. So I just wanted to share these preliminary, not yet published results with you to give you an idea that it's possible to do research into the types of questions we're asking here today and to gain knowledge that can help us to use technology in a way that is more human, that encourages a human interaction and a less isolated, distanced interaction. The ethics of telemedicine is a new field. There are not many papers in it. Most of the questions that come up have to do with cost, risk-benefit. Not all locations have high-speed connections, but I don't want to deal with those issues. We're concentrating on the human element. This article by Kahn and Walter in the AMA Journal of Ethics last year on telemedicine made a point that is worth bringing to the attention of this group. They felt that the use of a remote expert cannot replace having someone physically present at the location. There's something important about presence. In our consultation setup, we interact with a physician in the emergency room seeing the patient. So it's not just the neurologist on the camera interacting with the patient. We have that triad at work. And that's probably essential in making it work humanly. There are other authors that say, well, virtual doctor visits might even be better than in person. It's convenient, scheduling-wise. The waiting room is more pleasant if you're sitting by your computer compared to sitting in a room maybe with crying babies or having to wait. More convenient. Patients feel like doctors pay attention to them. So it might be used well. And then that launches us into avatar ethics. If ethical behavior could be programmed into a virtual physician, a digital substitute for us, would patients perceive that as character? Maybe. Would that truly be virtuous character? No, I don't think so. But suppose technology could give us a hybrid or a chimera, where our interaction with the patient is partly designed by or run by technology and partly us, and then partly how technology changes our appearance or our communication with the patient. So an augmented digital representation, how would we view that kind of mixture of human interaction and technological expertise that changes who we are. And you've all seen this movie, The Wizard of Oz. So we would have kind of the wizard magnified to a new level. We can control the size of the face, the volume of the voice, the gravitas of the all-powerful wizard. But it's been a generation since that movie came out. Couldn't we also now augment the compassion in the voice expressed by such a wizard? There's the area of research, affective computing, that Roz Picard at MIT is a champion of, learning how to communicate with patients electronically in ways that sounds compassionate and sensitive, to connect with people's emotions. Maybe digitally change the facial expression to appear more empathetic. I might frown at my end of the camera and the software would convert that to a smile. In principle, that could be done. So we have these capabilities that introduce interesting new questions. And suppose the next generation of mandatory medical practice algorithms were embedded into artificial intelligences imitating the human element, supplying the avatar, the artificial intelligence, if you will, with reasoning, judgment, moral decision, effective action. What would our ethics of that field look like? Is there something about technology something else about the bedside encounter that technology cannot supply, an aspect of human authenticity, if you will, that cannot be reduced to behavioral algorithms, something that can't be mimicked effectively by a computer? I'm essentially asking if there's a Turing test for distinguishing between the person on the screen is a physician asking you questions and an artificial intelligence, an avatar, performing that role. Where's the difference? And the difference is what it means to be human. I touched earlier on virtue ethical theory. Ed Pellegrino, who's written on virtue ethics, advocates for a virtue-based ethic in medicine. There exist three main arguments from his writing. There exist difficult cases where it's unclear how even well-formulated moral principles and rules ought to be applied. So we need another element, that is virtue, in order to prioritize, to differentiate, to take that added step of making a sound judgment. Secondly, virtue ethics, he argues, is superior to other ethical approaches because its adherents demand more of themselves than the prevailing morality. Rules don't give us all the answers, and there's something perhaps more virtuous than following rules and being compliant. Third, virtue ethics allows for a greater degree of sensitivity to moral complicity and accommodates the idea of a right of conscience. It is possible to be compliant with rules and yet be morally mistaken. In contrast to his three arguments, I'll present you with counter-arguments by Jansen, who wrote a paper in the journal Theoretical Medicine in 2000, who disagrees with Pellegrino on all those points, pointing out that virtues offer nothing beyond rules and abstract principles. And there's nothing special about virtue or anything distinct from what we have in secular ethics. Virtues are only derivative in significance, says Jansen. And striving for moral excellence can be expressed just as well in a principle-based or duty-based approach. And thirdly, emphasis of virtue underestimates the resources of those other approaches. Good character does not ensure correct action. It's possible to be virtuous and yet mistaken. It's always possible to be mistaken. And the reason that I'm presenting you with these three different ways of looking at virtue ethics is not to try to resolve which is true, but which fits better with the two approaches to medicine that I've presented you with, the human approach or the approach that relies mostly on technology. So if technology could substitute for the physician, which perspective on virtue theory would fit best? And I would say that Jansen's approach to virtue ethics, saying it adds nothing, all we need is rules and principles, could be fully fulfilled by a sufficiently advanced computer or artificial intelligence. You would not need the human element in medicine. Whereas Pellegrino's approach to virtue ethics requires something that a computer, no matter how sophisticated, cannot fulfill. That is, an avatar cannot be virtuous by its nature. That's my perspective on that question. So I think that this sort of gets at one of the defining elements of humanity as we discover it in the realm of medicine, and as technology helps to illuminate something about humanity that technology cannot fulfill. Already, physicians may be thinking about patients differently in subtle ways because we interact by computers more than we do face-to-face. Kaplan and Litewa in the Cambridge Quarterly of Healthcare Ethics state that already physicians viewing patient images may consider the image more real than the actual patient. What is a person? And electronic medical records, we're presented with information on a screen, not necessarily a picture of the patient's face. And this is the information that we're interacting with. The screen is a representation of the patient, not an actual person. We see numbers and text, no voice, no facial expression, no sensitive, fragile voice. And as electronic medical records, which by and large I think are a good thing, as they demand more of our attention and compete with the attention that we used to give our patients, does that mean that we might slip into thinking of the patient more abstractly and more like a thing and less like a person? So we need to be on guard in that area. Patients also may be communicating differently through electronic means with us than face-to-face. And I'll point out one example, a study of using a computer-based interview for screening blood donors for risk of HIV transmission discovered that people who answered questions in a survey were more likely to confide risk factors for HIV than they were in a face-to-face encounter. They were more likely to be truthful or forthcoming with that information. So patients filling out medical information on a computer or on a survey where there's no risk of being judged for that information might communicate differently than in a face-to-face encounter. Patients are also viewing us through digital interfaces on the web, oftentimes before meeting us in person. I know that's true in my practice. The percentage of patients who research their doctors online is and these are old numbers, it's above 50% now, so it's not uncommon a patient comes to see me, they've already been reading about me on the internet. And so to take some control over that, I have my own personal web page that says about me what I want to be seen in public rather than what people happen to find. Prediction number one, I have two predictions out of this. In the distant future, I'm not saying when, it may be considered scandalous to discuss one's private medical details personally with a doctor when such information can be disclosed more discreetly to a computer empowered to process that information and advise without fear of shame. This is assuming the NSA doesn't keep files on all of us. But it might become more socially acceptable to share very private, sensitive information in an electronic way. It's going to end up in the electronic medical record anyway. If you take out the human element, is that better or not? But this my first prediction. My second one, in the distant future, human physicians will find it difficult to compete in the healthcare marketplace with glamorous avatar doctors, non-human digital images that are instantly accessible, plugged into the full repertoire of current medical knowledge, mimic human compassion but do not judge, and are less expensive. There's already literature on the prospect of dermatologists and radiologists being kicked out of business by computers that are able to recognize something like a skin cancer or a tumor on an X-ray more quickly, perhaps as accurately, maybe more accurately than a physician. That's one set of skills in medicine. Our human interaction is another set of skills that computers could, in principle, eventually imitate. And if it's less expensive, and if the outcomes are similar, what's left? What's human about medicine that we should hold on to? You can even go online and get your diagnosis, perhaps. How accurate is Dr. Google? This study in 2006, well, first of all, the Pew Center found that 35% of U.S. adults have gone online to self-diagnose. You've got puzzling symptoms. Maybe you can't get an appointment with a doctor for several weeks. You want to find out what's going on, so you go to the internet, to your immediate source. This one study looking at Google as an internet-based diagnostic study found that they were correct in about 58% of the time. So a 50-50 chance perhaps of getting the right answer. But sometimes patients get the answer they need this way. Sometimes they get terribly misled in the wrong direction by information on the internet that can lead them very much in the wrong direction. This is one company that offers online diagnosis that I found. There are a number of them out there. I don't endorse any of them. I think it's better to have a consultation with a real physician. But this company claims that you can obtain a personal diagnosis without a doctor, and this software is operating in the same manner as the doctor, in other words, doing what the doctor does in terms of processing the information you submit. And it has a friendly face with it. We don't know who this person is who's playing the doctor, but you know, it's a nice profile. Yeah, but well, he's probably going to tell you not to eat Kentucky Fried Chicken. Is my guess. And then some of the you know, the really posh advertisement on this webpage. Well, this is what they offer: computerization. I mean, they have the whole medical literature right there. You know, instantly accessible. We have to look it up, but you know, they're plugged in, and it's scientific. They say all you have to do is show this research under a magnifying glass, and they've made the case that it's scientific. Okay, well, it uses scientific words at least. But these can be really dressed up and can look very appealing and can look like they're accurate, scientific, even compassionate, very human, increasingly human. This is a list of other such companies. It's kind of interesting, this one consultation service online, and none of this is in person. This is all electronic. $3,000 per consultation. And I know of another one that costs even more than that. Some of these, you know, you get on the phone, you have access within 11 minutes to this one, $45 per consultation. The quality of that consultation, who knows? It may be a nurse at the other end of the phone, there may be a triage, but these are starting to catch on. This one's called The Doctor Is Always In, $40 per 15 minutes. It's like a taxi. Concierge medicine for everyone. That sounds pretty egalitarian. Still $100 a month for that service. But concierge medicine usually doesn't give you everything you need. It's only a first line, and then there are referrals and tests and so forth. So beware. But these things are sort of slipping in to medicine, and it's technology more than the human element in medicine, and we should be critically evaluating that with an understanding of what it means to be human. So in conclusion, technology continues to alter how humans communicate and relate to one another. It may empower, it may enslave, it may do both. Technology may enrich or degrade what we value as human and how we value others. Ethics is not only a set of abstract ideas and rules, but it is embodied. It's a deeply human endeavor. Authenticity is a virtue unavailable to the avatar. And our experience with technology illuminates what's missing in technologies that mimic humanity. And those aspects of being and acting and interacting that in so many surprising ways defy translation into a tidy set of rules or lines of computer code, aspects that are impenetrably, indecipherably, irreducibly human. And as always in ethics, I've raised more questions than I've given answers to. I'm going to leave you with a closing thought. The Word incarnate, who is fully God and fully man, communicated his humanity by dwelling among us in person, in every sense of the word, in person. And yet, one way that the Holy Spirit has communicated Christ's humanity to us is through technology, even at the time of the writing of the New Testament. And I researched and found these technologies that were in place for simply writing down and transmitting the Gospels. The biblical text was put into writing using cut and pressed strips of papyrus, parchment treated with lime water, rubbed smooth with pumice. These are technologies. The writing was done with styli made from metal, ivory, or bone, reed pens sharpened to a point. That's technology. The ink was made from lamp black and gum dissolved in water from nut galls of oak trees. These are technologies. So technology has been used to transmit to us even this message, which we think of as being spiritual. So, of course, I'm not against technology, but how it's used is very important, and it can be used to emphasize the human element, even the divine element. And it doesn't necessarily degrade humanity, although it certainly has the potential to do that. So we want to be very intentional about how we apply technology and wise in how we use it or avoid it.